one of the major reasons for reducing popularity of cemented hip is the fear of bone cement implantation syndrome. The fear is so much that some of the centers in our city have given up using a cemented hip, and surgeons also advise against it. But is there truth in that? Should we be worried, or should try and get over this fear? So bone cement implantation syndrome is the hypoxia, hypotension, or sometimes the loss of consciousness that comes up when you are cementing the hip, or when you are reducing the hip, or sometimes when you are deflating the tunic in the total knee replacements. Occasionally it can progress to cardiac arrhythmias, and rarely some arrest can be seen. So when can it be, when do you get it? It can happen in any cemented procedure. It may be a bipolar, a THR, a revision THR, a TKR, uni, revision TKR, or a shoulder arthroplasty. It is even reported in vertebroplasty and kyphoplasties. The incidence, if you go through literature, ranges between multiple series from 15 to 30%, but the severe type of reaction is seen in about 3 to 8% of the cases, and rarely the mortality, if you see, ranges from 0.2% to 2% in some of the series. Not only the perioperative mortality, but there is also a high 30-day and 1-year mortality associated with the severe grades of BCIS, and hence we need to really try and avoid this by taking a few careful steps during your procedure. First is to understand why is this happening. Initially it was thought that monomer is the main reason for all this, and the monomer in circulation induces all these changes of hypotension and hypoxia. But studies have shown that the levels of monomer in the circulation is not always very high and does not explain for all the changes. The most widely accepted or believed reason is embolism. Embolism can occur whenever there is increased or high intramedullary pressure during cementation or introduction of your prosthesis. The debris contains fat, marrow, cement particles, air, bone, and aggregates of platelet and fibrin. This embolus usually goes and lodges into the pulmonary circulation. Sometimes it can escape through the patent foramen ovale and go into the cerebral or the coronary circulation and causes all the changes. So mechanically it can induce damage to the endothelium, which leads to reflex vasoconstriction, which can cause some amount of problems there, or because of the vasoactive and the chemical mediators that it releases, you can have increased the pulmonary vascular resistance or decreased systemic vascular resistance, causing hypoxia and then hypovolemia and hypotension. Also, sometimes the amount of embolism that is seen in the circulation does not correlate with the hypotension. So some people thought it was something else, and they have found that there is always increased levels of histamine in the circulation when in a hypotensive patient, and they thought it was something like a type 1 hypersensitivity. Also, levels of C3A and C5A are high in these patients, and they also lead to vasoconstriction and bronchoconstriction. So these also do play a role. So now it is believed that all the above processes play a role, and it is a combination of everything, and how your patient is going to react will depend on what kind of physiological response the patient gives to the episode, and also his physiological reserves. So initial episode is increased pulmonary vascular resistance, which leads to right ventricular ejection fraction reduction, which then the right ventricle dilates and it pushes the intervertebral septum into the left ventricle, and ultimately leads to reduced filling of the left ventricle, leading to cardiac reduction in cardiac output, leading to hypotension, and sometimes further leading to arrest. So Donaldson in 2009 introduced us to the grading. 90% of the time you have a grade 1 kind of a reaction where the hypoxia, the O2 falls up to 94% but does not go below that. The hypertension, the systolic blood pressure does not go below 20% of the baseline. Type 2 reaction or the grade 2 reaction is where the hypoxia is severe and the PO2 may fall up to 88%, or the BP may fall more than 40% of the baseline, and sometimes you get unexpected loss of consciousness. Grade 3 is when you have frank cardiovascular collapse and which needs CPR. So the best way to reduce the incidence of this syndrome is trying to anticipate it, then detect it early and aggressively manage it. We need to identify your high-risk patients, and then so you can anticipate the problem, and by increased monitoring we can detect early changes and then aggressively manage it to avoid any problems further. So what are the risk factors? The ASA grade 3 and 4 patients are associated with higher degrees or higher grades of BCIS. Older patients, male patients are known to have higher chance. Patients who have COPD or old cardiac diseases, or they have pulmonary hypertension, or even renal patients with raised creates are known to have higher incidence of BCIS. Osteoporosis, metastasis, fractures, especially pathological and intertrochanteric region, is known to have increased vascularity in the region and opens up abnormal vascular channels through which embolism can occur. Revision surgery obviously is longer and is going to be there's going to be a lot more blood loss, so there's a higher chance there. If you have a previously uninstrumented femur, then there's a higher chance. Use of longer stem is also known to be associated with BCIS. Again, patients on diuretics or on warfarin, you need to be more careful because again there's a higher incidence there. So once you have a patient, you need to recognize the risk factors in your patient, and you need to discuss it with your team. Your team needs to be your anesthetist and your intensivist, and three of you all together need to realize and analyze the patient and do the best what you can do. Try and optimize the patient's pre-op condition by managing the comorbidities. Again, discuss the management with your team and assign roles to each team member and decide what is to be done. Discuss with the surgical team when all this can happen during canal entry or reaming, or when cementing the acetabulum or the femur, or while inserting the prosthesis, or while reducing a joint. When it comes to anesthesia, literature advises us that the best anesthesia in this patient is a low-dose spinal with epidural with preferably no sedation. Generally, GA should be avoided as it involves nitrous oxide and volatile drugs, which again increase the chances of embolism. And again, in epidural, plain or simple epidural again is not very good because you can't control the hypovolemia very well. So you need to sit with your team and make some kind of protocol. I like this cement curfew protocol, which is followed by Coventry University Hospital, and it helps us prepare everyone, all the team members, as to how and when you are going to do the things and what role does everyone need to play. So this is what we follow at our institute. Basically, when there is a high-risk patient, the monitoring increases. The BP and PO2 and ETCO2 is monitored every 2 minutes instead of normal 5 or 10 minutes. Fall of the end tidal CO2 is usually the first sign of BCIS. So be aware, talk to your anesthetist and be aware of this finding. As soon as there is a change, you need to aggressively try and manage. In our institute, they always put a central CVP line so that they can replace the fluid properly and not overload the heart. Occasionally, SVC filters have been used where there is a very, very high-risk patient, but we had to use a cemented because of osteoporosis. The first clinical sign would be delirium, loss of consciousness, or dyspnea. So anesthetist has to be very aware of this, and they need to be talking to the patient or interacting with the patient to understand the occurrence of this. Again, they need to prepare for a severe reaction and be prepared for a CPR. The anesthesia team needs to be alerted before we start our cementing, so that they ensure that the fluid is properly replaced, and the blood pressure should usually be within 20% of the pre-surgery baseline. They should start oxygenating the patient. Sometimes drugs like corticosteroid, antihistaminics, and bronchodilators are used. Some centers have advised low-dose epinephrine to try and maintain the blood pressure or raise the blood pressure before cementing. Our anesthesia team always keeps the inotropes and vasopressors ready in case there's a collapse. Again, there has to be, every time when you are changing or doing your process, next step, you need to be speaking to anesthetist. They need to be aware of the progress of your surgery. They need to be highly vigilant for any changes, and our team normally says they treat it like a right ventricular failure. So as a surgical team, what do we need to do? The first step that we need to do is try and achieve very, very meticulous hemostasis, as any blood loss could lead to hypovolemia, which again would precipitate this problem. When your preparation starts as soon as you open the canal. As soon as you open the canal, suck out all the content from the canal. Then give a copious lavage. Preferably, I use a pulsatile lavage. Give enough lavage so that you are very happy that you have sucked out or removed all the debris from your canal, and your suction, what you are sucking, is absolutely clear. Now you can prepare your canal with your broaches. At the end of your preparation, brush and plug your canal and dry the canal, and then pack it with a vent the tube needs to be continuously attached to a suction so that it keeps on sucking out whatever debris or blood loss or blood or air that gets collected there. Then again, inform your anesthesia team before you start mixing, and be sure that they are prepared with their preparations. Use of low viscosity cement is known to be better, as it has lesser incidence of BCIS because of the less pressure that it generates. Vacuum mixing the cement reduces the monomer vapors and definitely helps in reducing embolism. Retrograde filling the cement using a gun and with continuous suction through the vent is definitely useful in reducing embolism. Avoid excessive pressurization. Sometimes if there's a high-risk patient, you can reduce, or you can be a bit lenient with your pressurization to avoid changes. Again, when you insert your prosthesis, you should not be using force or hammering. Gently introduce it. Use stems as short as possible, because long stems are definitely known to be associated with BCIS. Then gently reduce your hip. It's advisable not to hold your limb in flexion and internal rotation for a long time, because that leads to kinking of the vessels, which can again cause stasis and turbulence, and which can cause embolism, which then releases into circulation when you reduce it. So try and release that extreme position as much as possible. Usually BCIS sets in about 10 minutes after you've introduced the cement. So, and usually you get the changes between 10 and 20 minutes. Beyond 20 minutes, generally you do not see any changes. So be very meticulous, or be very alert. Observe the patient for about 20 minutes after you've introduced cement and prosthesis. If there is an issue or a BCIS sets in with this, then the anesthetist needs to take over and resuscitate the patient. Sometimes there was an occasion, I remember, when I had to turn the patient from lateral to supine, and they had to resuscitate the patient, and then we turned the patient later on and then finished our procedure later on. So the best to avoid the severe reactions in BCIS is to anticipate it in our high-risk patients, then detect it by early monitoring of your patients, and then prepare your team for aggressive and aggressive management of the problem, so that you don't have severe reactions and leading to increased mortality. Thank you for your patience here.